And we know that there are two different types of hormones. One, which are the ones which are the peptide hormones largely, and the other ones are the steroid, thyroid, that group of hormones. The major problem with peptide hormones in terms of their action is that they cannot cross the cell membrane. While steroids can easily cross the cell membrane, we already discussed that the peptide hormones act on what is the membrane receptor, while the steroids will be acting on the nuclear receptor. So what will be the difference in terms of the duration of effect of the lag phase?
Peptides have membrane receptors which have an almost immediate onset of action, whereas steroids will enter progressively, change nuclear manifestation and will have prolonged.
So generally they will have a lag phase because you need to have the protein synthesis to happen for their effects to really translate from that perspective, while you can have immediate effects from the membrane receptor in that regards. So hormone signaling, as discussed, involves the concentration of the hormone in the whole blood. But as I said, the concentration. So this basically is that the concentration of the hormone is the same in the whole blood, and then subsequent to that, the receptor effect will be deciding where it is going to work and which part it is not going to work from that perspective. So this hormone acts on the receptor at the peripheral action. Now we know that the membrane is a phospholipid bilayer, and you have got a lot of this area, which basically is the intracellular and the extracellular area. The inside, you will not have passage of the hydrophilic compound. You can have lipophilic, so you can easily cross the steroids and other things, but other parameters cannot be crossing that. So you have a hydrophobic region in between, which is basically the lipid region, and a peptide cannot really go through from that regards. While you can have a direct impact of different compounds, the steroids can go directly inside and it can act on its receptor. And thyroid is unique that it cannot cross, but it has got a very, very special protein, which we discussed, the MCT8, which will take thyroid inside. So depending upon the structure, you need to adapt in terms of the function. So steroids largely have an intracellular receptor. Peptide largely have a extracellular or a membrane receptor. And as Dhwani said, generally peptide, membrane receptor, immediate action, while steroids, intracellular receptor, genomic effect, slow action. But that's not entirely true. We know that many of these peptides, via the second and third messengers, will affect the gene expression. The classical example is the growth hormone pathway, which activates the STAT pathway, which results in the expression of genomes. And many steroid hormones can have an immediate impact using the membrane receptors. The classical are vitamin D, estrogen, who can have an immediate action in that regards, in that perspective. So receptors could be membrane receptor. The most common membrane receptor are the G protein coupled receptor. But these are very interesting receptors. So what the evolution has done is that it has produced a unique G protein, which is then having a lot of other subsidiary units, which then result in translation of different actions. All you need to do is to just modify its external domain so that it becomes selective to a particular ligand, and its internal domain to allow the action to be different. So on the same framework, you can easily produce a lot of other things. So G protein coupled receptors are the most common form of receptor that you will really encounter. Most of the normal stimuli other than hormones, like the light, the temperature, and the other things as well, these are all associated with the G protein coupled receptor, and it's the most common receptor in that regards. Most common pathway through here, the second messenger is cyclic AMP mediated, and we know that a lot of cyclic AMP mediated processes like TSH, LH, GHRH, GnRH, and all of them can be associated with problems in terms of McCune-Albright syndrome and pseudohypoparathyroidism, because that's a GNAS1 mediated action. Then you can also have the GnRH and TRH, which are the phospholipid related, and the other pathway. The cytokine receptor are the ones which are largely the growth hormone, prolactin and leptin, tyrosine kinase are insulin and IGF-1, as we discussed before. You now will go about the membrane receptors. So the classical example are the G protein coupled receptors, which have got 7 transmembrane units. So as I said, these units are same. You need to have a different binding unit out here and the action unit out here from that perspective. And this unit is going to connect the effect of that particular ligand to the G protein, which has got subunits. So you've got the alpha, beta, and gamma subunits which are there. The type 1 cytokine receptor are basically, you've got the extracellular and the intercellular domain, and binding of the ligand will result in structural change, resulting in the various effects and usually phosphorylation from that perspective. And of course, you will have the tyrosine kinase who have got an intrinsic tyrosine kinase in that regards. Now, G protein coupled receptor, as I said, the N terminal is the ectodomain, the outside domain, which is a serpentine. So you've got 7 linked chains, and the endodomain, which is related to the action point, which is happening subsequent to that, the G protein in that regards. Now, G protein, there can be multiple subunits. I'm not going to talk about lots. Some are stimulatory and some are inhibitory. The most classic example is the alpha, beta, gamma unit, which in the native state is in a GDP state. That means it is hypophosphorylated. When it gets activated, you have got the GDP, which is converting into GTP, and that will dissociate the alpha from the beta and gamma subunit, and then the subsequent action will happen. But you do not want this process to be continuous. So immediately you have got the GTPase action, and this is again going to convert into GDP, which is again going to bind again. So this is a very instantaneous effect on and off. You don't want it to be continuously on from that perspective. And then from there, you've got the messengers which are happening. Now, I said that you can have multiple pathways like light, odor, lot of hormones which are acting to the G protein coupled receptor from that perspective. So GPR signaling classically, if you have a ligand binding, the GDP is activated into GTP. Your alpha subunit dissociates from the beta and gamma subunit, producing one of the classical example is cyclic AMP using the adenine cyclase pathway, and the beta gamma go separately, and they can also activate other process. There is an intrinsic GTPase activity, as I said, which is going to switch off this whole process regulated via the RGSS or the regulator of G protein, converting it back to GDP, and your action is terminated in that regard. So it's an instantaneous, quick action. You want something immediately. You want the calcium to become inside the cell. You activate that. You want to have a specific effect of ACTH, you act immediately. So this is like an instantaneous process where you will like to have this sort of a thing in that regards. Now, very importantly, these receptors are, of course, produced in the cytoplasm, and they need to be pushed to the membranes. And this process requires the specific proteins which are known as receptor-associated proteins, and defects in these receptor-associated proteins can also cause different pathologies. Now, what are the defects that you can see of because of the receptor-associated proteins in these scenarios? Yeah. So, as you were discussing about familial glucocorticoid deficiency, which is basically a resistance to the ACTH. So, which receptor is responsible for ACTH action? So, MC2R receptor is defective, and because of the defect in the MC2R receptor or in the MRAP, which is the MC2 receptor associated protein, which will take this to the cell surface, you will have no ACTH action, resulting in a situation of hyponatremia, hypoglycemia, pigmentation, and isolated cortisol deficiency in that regards. Now, there are different types of ligands which can bind to this particular receptor. And when we talk about ligands, this is the basis of therapeutics. So we have got the natural ligand, which is going to act there. And then we've got the agonist and the antagonist. What is the difference between agonist and antagonist? Yeah. So it will act like the ligand. So if you have, let's say, ACTH, you've got a synthetic ACTH, synactin, which is working, it's like an agonist. What is antagonist?
Not allow the ligand to act on the bind on the site.
Okay. Yeah.
It will terminate the action of the.
So it will block the action. What about inverse agonist?
It will reverse the action of the.
Yes. So you need to understand the difference between an inverse agonist and an antagonist. Antagonist is just going to block that. It's going to block, occupy, do nothing. Agonist is working on the receptor to do a positive activity. I'm saying positive in the terms of its activity. Antagonistic is just occupying the receptor, doing nothing, while inverse agonist is doing in the negative direction. So that's a major difference. So it will have a more impact in that regards. So you have agonist, inverse agonist, which is going to block this process, and antagonist, which is just going to be there in that scenario. Now, from here, you have got the second messenger, and the classical second messenger is cyclic AMP, which is produced by the ATP adenyl cyclase pathway. And we know whether we talk about the arginine vasopressin, we talk about LH, we talk about FSH, we talk about PTH, MSH, all of them are associated with the cyclic AMP process, which activate the protein kinase A. This cyclic AMP is inhibited via phosphodiesterase. So what are the conditions in which you will have more cyclic AMP? And you've got more cyclic AMP, you have a greater risk of tumor formation or oncogenesis. So based upon these pathways, you can talk about. Yes, that's true. True. So your protein kinase activity is more, so that's distal to the cyclic AMP action. Then phosphodiesterase, if this is not acting, you will have also an issue of cyclic AMP. So when we talk about Carney's complex is basically PRKAR1B, which is associated with a more activity which is beyond the cyclic AMP. Some variants also have a problem in the phosphodiesterase, because the cyclic AMP is not getting exhausted. Having too much cyclic AMP is not good. It is going to cause more cellular growth and more issues from that perspective in that regards. And then phosphorylation happens. There are other second messengers like cyclic GMP. Which hormone acts via cyclic GMP? Nitric oxide, true. And then some of them have calcium and IP3 DAC. Those pathways can also be there from that regards. Very interestingly, one of the second messengers is CREB. And this CREB is going to the nucleus and regulating the expression of the genomes in that perspective. So what it is telling you that some of these membrane receptors may have a genomic effect as well, which are longer acting in that regard. So GnRH and TRH act via the IP3 pathway in that regard. So we've talked a lot about the G protein receptor. What about the cytokine receptor? So these are classical examples, growth hormone. So here you've got an extracellular domain and an intracellular domain. When the ligand binds to it, it basically results in, brings it like a scenario in which they will come together. The internal part will open up, and they will open up. And in that regard, like scissors, you're closing this, the inter part opens, and the ligands come close, and you will activate the JAK phosphorylation. And then you have got the STAT, the JAK-STAT pathway will get in. And again, this is going to act on the nuclear part to produce steroid response, the STAT responsive elements in that regard. So growth hormone, prolactin, and leptin, they are all going to act via the cytokine receptor, and therefore you will have overlap, which is also going to happen in that regards. Insulin receptor is a unique type of receptor of the tyrosine kinase. It has got an inherent tyrosine kinase, which is there. Again, you've got two alpha subunits, and then you've got the beta subunits. In growth hormone is like scissor. When the outer units are coming close, the inner ones are going out. Here it's the opposite. When you have binding of the insulin, there are two areas which is going to have a negative cooperation. They will come close, and once they come close, the intercellular domains also come close, and these tyrosine kinase will then autophosphorylate the other chain. And this process will then trigger the whole pathway. And we know that there are two different major hormones acting through this pathway, the insulin and the IGF-1. The IGF-1 has a predominant effect on the mitogenic pathway. It's going to activate that, while this will have a major impact on the glucose or the metabolic pathway from that regard. So IRS1 and 2, which are the insulin-related substrates 1 and 2, which are in fact the major site of action of which drug? Metformin. So metformin increase the IRS1 and 2, and that play an important role from that perspective. And this will result in glucose entry into the cell. So as we say, if somebody is insulin deficient, it's like swimming in seawater. You got a lot of water, but you cannot take inside. Similarly, when somebody is having diabetes, his glucose levels are very high, it's circulating in the blood, but you don't have the key to take it in. The key is actually GLUT4, which is activated via insulin. And insulin deficiency, you can't use that in that regards. Then, of course, you've got the MAP kinase pathway, which is the mitogenic pathway. And we all know that insulin acts on the IGF-1 receptor. It has got homology, and insulin receptor itself has got a growth promoting effect. That is why one of our significant determinants of size at birth is insulin. And we know that if you have neonatal diabetes, you are SGA. If you have neonatal hyperinsulinism, you are LGA because of this insulin effect. So IGF, platelet-derived growth factor, FGF, they will all act via this whole pathway. What's unique about FGF receptor compared to the IGF receptor, structure-wise? Alapan? It has got a single chain. Others have got double chain. FGF has got a single chain in that regards. Now, the last group of receptors are the nuclear receptors, which is going to basically regulate the transcription process. And in this scenario, the hormones will go into the nucleus, bind to the receptor, activate the responsive element, result in mRNA, and activate the production of a protein. The classical example, of course, is all type of steroids, whether it is cortisol, aldosterone, estrogen, testosterone, then vitamins, vitamin D, of course, we know that some of the metabolites and thyroxine also have an internal action in that regards. And a lot of xenobiotics are also, which are basically produced in response to the external agents, they become also act on that perspective. So nuclear receptor typically has a typical structure. It's got a trans activation domain, which is in the N-side, a DNA binding domain, a nuclear localization domain, and a ligand binding domain. So you have got a ligand binding domain outside in which your hormone will come into. Once that's bound, the D area will take it to the nucleus. It will then go to the nucleus. Often they will dimerize with a similar structure or with RXR, the retinoic acid receptor. Then the C point will go to the particular DNA binding point. So they will act like a transcription factor. So every nuclear receptor will have a particular point where they will bind. And then you have the trans activation, which is a non-specific process which will increase the whole process. So the most important part, of course, are the ligand binding domain and the DNA binding domain. And the site of defect of that particular receptor will have different implications in terms of expression. Which disorder is a classical example of huge variation in terms of activity depending upon the nuclear receptor site of action. And we know that it's one of the most heterogeneous resistance disorder, hormone resistance disorder. So it has to be a steroid. So which is the most common steroid resistance scenario you're thinking of? Yes, so AIS. So the androgen receptor has got multiple manifestations depending upon whether your ligand binding, so if your ligand binding domain is affected, then maybe you are partially binding to it. But if your DNA binding is there, you will have no effect at all, even if you are binding to that. So that's why you have got an AIS, which is starting right from a complete AIS of a normal looking female with primary amenorrhea, normal breast development and inguinal gonads, to a normal looking male, the minimal AIS, who is just infertile or who just has some erectile dysfunction. So that is why this androgen receptor is a classical example where you'll have huge sites of defects which will determine the phenotype, the genotype correlation which happen in that regards. So in the native state, you've got this dimerization which is there, you've got no ligand. So what will happen? You don't want to produce proteins. You will be in a suppressed state. So there are co-repressors which are going to repress this activation, and classically the NCOR SMRT pathway are there, and you have got the deacetylation and you will have an imprinting. So the key is closed, no product being formed. Now, if you now have a ligand, So what essentially, you need to understand what does the ligand do. Everything is already there. So you are not waiting for cortisol to be there to get all this thing happening. Everything is ready. So body is ready, waiting, but it has sealed it up, locked it up because it's not required. But as soon as your signal is there, suppose your cortisol hormone comes in, the co-repressor goes off, the co-activator comes into the picture, and your imprinting process goes for a 6. It's gone. So now you will have the different enzymes which will come in. You've got co-activators like P300 and PCAF, which will have the histone acyl transferase. This is going to change the whole structure, unwind the whole protein. The histones are going to be unwound, and you will then have the removal of the suppression, and you will produce the RNA that is required. So this is very important. You don't want to continuously produce a process. You will do it only once the ligand is there, and that too above a particular constant. Is the audio clear now? I think there was some problem in the audio. So I think it must have now got rectified. So we were discussing about why do we need to have a repression. So it's like 3 regulatory region. Suppose you keep it at 0 and you go to 1, you will have some increase. But if you are in negative and you go to that, you will have a multiple effect. So body keeps things at suppressed mode to begin with. And once you have the suppressed mode, it then you have activation, you will have much more difference. So it will go 15 times. Like we say, LH goes 15 times. You will have a much better factor. Regulation will become more precise in that regards. So we'll just check if there was an issue in terms of audio. Okay. So we will continue in terms of the effect of the ligand binding. And we said that you can have activation once you bind it. And this activation results in amplification because it's already been repressed. And now suddenly your action becomes much more from that regards. There are certain scenarios where your binding of the hormones can decrease the production of a particular gene product. Can you name a certain scenario? So let's say calcitriol, what gene product will it bring down? It will decrease PTH. It will decrease the 1-alpha hydroxylase. So you also need to have a suppressing effect as well. It's not that they are going to work only to increase the level. So like cortisol, if it becomes more, it will suppress ACTH. So therein you want to have a suppression also which happens. So there is a trans repression. So the intracellular action of these enzymes, these hormones will result in activation as well as suppression depending upon the particular site. Now, hormone action is very, very important because multiple pathophysiological processes are because of the hormone action defect. So we know that if you have a problem in the GHRH receptor, you will have the growth hormone deficiency. If you have defects in the MC2 receptor, you will have the familial glucocorticoid deficiency. Androgen receptors, you have got the DSD, or the LHCG receptor also you will have GSD. On the other hand, if you talk about excess, you can have growth hormone excess in the setting of GHRH excess or McCune-Albright syndrome, in which the enzyme is working more. If the ACTH is working more or the GNAS1 is working more, you will have Cushing syndrome. You may have precocious puberty. What is the classical example of hyperactivity of a particular receptor causing precocious puberty? Means the receptor is working more. No. In precocious puberty, pure precocious puberty. Yes. So testotoxicosis. So your LHCG receptor will be there. So if you think of it, you will know, okay, LH is more, what will happen? LH is low, what will happen? So LHCG receptor defect will cause DSD. LHCG receptor hyperactivity will cause testotoxicosis. Nothing in females. That becomes important. Thyroid, if you have a problem in the TSH receptor, you have hypothyroidism with apparent athyrosis. You will have no thyroid gland on scan. While if your TSH receptor is hyperactive, you will have an autosomal dominant permanent congenital thyrotoxicosis. So you'll have a child who is born to a mother who has a goiter, whom you have labeled as Graves' disease, and now he presented you with Graves' disease, but he is not going off as far as the antithyroid drugs are concerned. So what clearly means is that this child has an activating TSH receptor, and that's going to cause a lot of issues from that perspective. So you will have hypothyroidism and thyrotoxicosis. Similarly, you can have problems in terms of diabetes in scenario where the insulin action is less, typically in the form of insulin resistance syndrome like Rapsen-Mendenhall or Donahue syndrome in that regards. At the level of adrenal, you can have cortisol resistance, which will typically present to you with somebody who has got features of cortisol deficiency, who has pigmentation, who has hypertension, hypokalemia, alkalosis, hyperandrogenism with a high cortisol and a high ACTH level, which is there. In the level, you will not have increased sensitivity. It's extremely difficult to have an increased sensitivity to steroids. Problems in the parathyroid receptor or the GNAS1 action will result in pseudohypoparathyroidism. We all know that. Hypocalcemia, hyperphosphatemia, and high phosphate. Pseudohypoparathyroidism was the first endocrine resistance syndrome which was discovered. And you can also have an increased sensitivity which will result in neonatal severe hyperparathyroidism. Then, of course, at the level of testis, you can have androgen insensitivity syndrome, which we discussed, or delayed puberty because of a FSH receptor scenario from that regards. So you have a 2-year-old boy with failure to thrive, hypoglycemia, which is ketotic, hyponatremia with hypokalemia. So this could be a case of primary adrenal insufficiency, Alapan. What is against primary adrenal insufficiency in this case? So there is no hyperkalemia. Definitely there is not even normokalemia. There is hypokalemia. So which condition will cause hyponatremia and ketotic hypoglycemia? So you have a problem in which hormone? You have a problem in ACTH. So either ACTH is not there or it is not acting. So your cortisol is low. Now, if you think of Addison's, it's unlikely because I said this potassium is on the lower side. So you're looking at impaired aldosterone effect. So your ACTH level will give you a clue. There clearly is pigmentation. So this is a problem of ACTH resistance or familial glucocorticoid deficiency. 5-month-old boy with failure to thrive, Dhvani, fever, recurrent dehydration, hypernatremia with low urinary osmolality. Which receptor you think is affected? Yes. So we have discussed that unless you have a CNS malformation, central DI is very, very unlikely to present in a genetic form before 2 to 3 years of age because of it's a splicing defect. It's a 2-hit model. While nephrogenic DI typically in a male less than 1 year of age, failure to thrive, fever, dehydration, hypernatremia, this could be a classical case of nephrogenic DI. There was also a polyamnios and family history. So this was a V2 receptor defect which was there. 8-year-old girl with developmental delay, hyponatremia, and your urinary osmolality is 180. Comment about this combination. You think this urinary osmolality is low, normal, or high for the level of hyponatremia?
Plasma osmolality is high. No, sorry, less. Plasma osmolality less. So in a state of less plasma osmolality, we expect urine osmolality to be low.
So this is low or not? That's what I'm asking.
Low.
This is normal. So this urinary osmolality of 180 is low. When you say urinary osmolality of 180, urinary sodium would be like 45 because 4 times. So for this hyponatremia, you should actually have a urinary osmolality less than 100, which means that you have a dilute blood and you have got a concentrated urine. What does it mean? That means that your AVP is acting more. There was no response to fluid restriction, no response to tolvaptan. Somebody thought this is SIADH, but gave them V2 receptor antagonist. Also, there was no response. What do you think? So now if you club this, what case was discussed just before that? That was V2 receptor resistance. This could be a V2 receptor hyperactivity. So always think in terms of endocrinology that you can have hyperactivity and hypoactivity. So AVP levels were low, but despite that, you have got a high level of this particular scenario. So this is basically a scenario of V2 receptor mutation. So this you can say as nephrogenic SIADH. Like that was nephrogenic DI, this is nephrogenic SIADH. So just think logically, you can get to the diagnosis even if you have not heard about that, even if you have not read about that. In endocrinology, you can just do some calculations, think what could be wrong. So what you are seeing here, there is features of AVP excess. Euvolemic hyponatremia with high urinary osmolality for that level of urinary, for that level of sodium. Now there is a AVP level which is very low. So that means the AVP is working, but the level is low. That would basically mean that there's a problem in the V2 receptor, and that's why your tolvaptan is not acting. So again, it becomes important. 4-week-old girl with atypical genitalia. What do you think is that there are inguinal gonads with no uterus? So I think you know that this we are talking about a XY DHD. Now karyotype is XY. Expected testosterone is undetectable. So you've got no testosterone there. Now, sodium status, there is normal growth development, there is no dyselectrolytemia, no features of CH. What are you thinking of in this scenario now? So,
in the line of 70 meters,
yeah, so you are going in that regard. So on this side of the algorithm. So LH was found to be very, very high. So this could be a typical HCG receptor. So we are trying to use all that we've discussed today to get to our diagnosis. 3-year-old boy with early puberty. He is 106 centimeters tall. SPL is 9 centimeters. Pubic hair stage 3. Testis is 3 mm. So what are the type of puberty you're talking about?
It's like more
Peripheral precocious puberty. Yes. So what you found that LH was less, FSH was less. As expected, testosterone is very, very high. Now, next step, of course, will be to look at the adrenal pathology. CT was normal, 17 OHP was normal, HCG was normal. So now what are you thinking about? So just the opposite of what Dhwani talked about, LHCG receptor defect presenting as atypical genitalia, LHCG receptor activation causing the testotoxicosis in that regards. Now, when you talk about action, there will also be overlap, and the classical overlap happens between glycoprotein hormones, the TSH, LH, FSH, and HCG. And we know that if your TSH is very high, it acts on the FSH receptor, causing large ovarian cyst, peripheral precocious puberty in girls, and large testis with no precocious puberty in the form of macroorchidism in boys. Placenta produces HCG, which causes increased TSH receptor activity, causing hyperthyroidism, sort of a state in pregnancy, which is there in this scenario. And you can have LH excess. So 7-year-old girl with thilarchy, Hilarki for 3 months, very, very short. She has got stage 3 breast development and she has got menarche as well. She is short. So I think the diagnosis is clear. So why don't every girl with prolonged hypothyroidism present to us with this picture? So we see so many long-standing hypothyroidism, not all of them develop ovarian cysts. Why? Yes, very good. So this is what we were discussing about yesterday, that if you have a FSH receptor, the sensitivity of FSH receptor will vary. So not everybody who is given LHFSH as part of IVF treatment develops hyperstimulation. For same dose, some people will develop hyperstimulation because their FSH receptor is more active. So suppose your FSH receptor is more or it's more active, even some amount of TSH can cause this. So this is because of the specific defect in that perspective, which is important. And this was classically a case of hypothyroidism. Infant of Graves' mother on methimazole, and you see that her FT4 is 32, TSH is very, very low. On day 14, so this was labeled as neonatal Graves, started on methimazole. The disease is persisting at 6 months. So what are you thinking of?
Is not working on the side from the infant.
No, methimazole is working. He's controlled, but you are not able to take off methimazole. Yeah.
Somatic mutation of the
Somatic mutation. Germline mutation, because there's a mother also who has got the same disease. The baby also has got somatic mutation, will cause a thyroid nodule. This is an infant who is presenting very early. The whole gland, the TSH receptor is hyperactive. So this is the classical example of TSH receptor activating mutation. 3-month-old child with failure to thrive, not gaining weight, hyponatremia and hyperkalemia, no pigmentation, genitalia is normal. And what you are seeing here is that PRA and aldosterone both are high. So what are you thinking of?
They are all the way high, they are not able to produce the required receptor at this stage.
So this is the inefficient aldosterone effect. As against the apparent mineralocorticoid excess, this is the mirror opposite. The problem here is at the level of either the ENaC channel or at the level of the mineralocorticoid receptor. So PHA type 1, type 2, whatever, depending upon the particular scenario. 15-year-old girl with primary amenorrhea, she has a height of 154, stage 4 breast, sparse pubic hair, inguinal gonads. I think the diagnosis is there. So this is a classical example of complete AIS. Ultrasound shows no uterus, XY karyotype, testosterone is high. So again, a scenario of high testosterone, high LH. High testosterone, high LH. It means high testosterone, high LH. What does it mean? So there is an androgen insensitive. High calcium and so high FT4 and high TSH. Thyroid hormone resistance. High calcium, high PTH. Calcium sensing receptor defect. So you can easily understand what is the sort of a problem in that regards, and this happened to be complete AIS. 1-year-old boy with bony deformity and refractory rickets, calcium is very, very low. Phosphorus is again low. So this is similar to a case we were discussing about, but this looks even more severe. There's severe hypocalcemia. PTH is very high. Vitamin D is hugely elevated. Calcitriol is also hugely elevated. So this is the, so this is a vitamin D dependent rickets type 2.